So hello everyone, welcome to tonight's talk organised by the Governors of the University of Derby and Burton Hospitals. My name is Val Haylett. I'm one of the Governors for City of Derby. I'm also chair of the Members Engagement Group, which is why I'm here tonight. Hope you enjoyed the pre-information meeting. It's always good to have a chat. Housekeeping first: in the event of the fire alarm going, the exits are to the side and to the back of the room. I would ask if you could all switch your phones off, please. I know some may have their phones on for medication reasons, but if we could have them fairly quiet, that would be very good. The talk this evening is being recorded and will be on the Governor's page of the UHDB website in about a week or two's time. To commence this evening, we are going to have a short talk by Ali Furlong from our Head of Fundraising for the Derby and Burton charities about the activities at the moment of the charity across the Trust. So Ali.
My installation's arrived.
Right, okay. Thank you, Santa.
Good evening, everyone. My name's Ali Furlong. I'm Head of Fundraising for the Hospital Charity, and it's really lovely to have a couple of minutes just to talk to you and just to let you know a bit about some of the things that are going on at the moment on the charity. So it's a festive update. I don't know if everyone's feeling Christmassy, but today we handed out patient presents to the patients today. So I'm feeling quite Christmassy because we have every patient that is in hospital on Christmas Day receives a gift from the charity. So we met with all the wards today and passed on their presents. So on Christmas Day, they'll be passed on. So that was really lovely. I'm just going to share a few slides with you. It's information that's on our social channels. So if you follow Facebook or Instagram, you can see all the things that I'm going to show you today. But just a bit of a roundup of what we've been up to the last couple of months. So there's been a lot going off with our wonderful supporters, and I just wanted to share a couple of people with you here. On the left is a gent called Martin. He's been dyeing his beard a different colour every day, every month, in order to raise money for the charity. He's part of the Micklover Golf Club, who are fundraising for us the whole year, but he has his own particular fundraiser, and his beard adventure this month is to have bells on his beard. So he's raised £1,600 with his beard antics, so that's absolutely brilliant. You'll also see in the centre our Star Supporters section. So every month we share all the supporters that we've been fundraising for us in that month and some of the amazing things that they've done. So that can we get lots of children, groups, businesses, community groups. The bottom left, there were an organisation called Belper Beats. They had a fun concert for the whole day and raised money for the Nightingale Macmillan unit. So we're super lucky to have lots of amazing supporters who help us out. We've also had a couple of things that we've reached out to the community and staff with. So we've got our Elf Day that's happening at the moment with schools. So we've got schools across Derbyshire and Staffordshire having their Elf Days and raising money for the charity. We know it's really difficult for schools to raise money, so we don't set them a target. We just say anything that you can raise makes a difference. And we take our mascot Lammy into school. So tomorrow I shall be dressed as Lammy, going to 2 primary schools and probably dancing around in assemblies to Christmas songs. But it's something that the schools really appreciate. And in honesty, it just gives us the opportunity to talk to children about being in hospital and about taking away some of the concerns that they might have about hospitals. So it's a really nice thing for us to do. And tomorrow is also Silly Sock Day in the hospital. So we're asking staff to wear silly socks for the day and make a donation to the charity. I know that Christmas jumper day is a big thing, but it's not always possible to do that in a hospital. So silly socks is our version of that. We also, 2 weekends ago, we had our Santa run. I don't know if any of you were in Derby at the time, but we had 700 Santas running around Markeaton Park. It was a sellout event, which was amazing to have so many people there. We had an internet sensation, Spudman, there selling his jacket potatoes. People were queuing for an hour and a half for a potato. But it was a great day, and it was so lovely to bring so many people together and just see people enjoying raising money, supporting charities, and a sea of Santas really is a sight to behold. We've also had some special visits in the hospital from some of our friends. So the Derby County players came into the hospital and met patients. They went to the Children's Hospital and also to the renal ward. And we had the Derbyshire County Cricket team also come in this week and go over to the Florence Nightingale Hospital. So it's always lovely to see how patients respond to that. You know, people can be kind of having a very quiet day, and then someone comes in, and there was a gent who really is really into his cricket, and he was talking to the players, and it's really nice to have the opportunity to have these visits from people. We've also had lots of exciting things that have gone on around some of the money that we spent. So there was a festive fun day in the children's with a little pony. And in the middle section, just one of the things that we've recently purchased is some improved seating for in the paediatric high dependency unit. And you can see Dasher and Dancer on the right-hand side. So we had a reindeer day last week in the Nightingale Macmillan unit, which is just a lovely way of celebrating Christmas and bringing people together. There was also Santa, choirs, all sorts going on. And just to share something really exciting that's happened in Burton, as you may have seen here, we've got the badgers, the willow badgers. They didn't have anything similar in Burton, so now they've got their swans. So if you go into Burton Hospital on the right-hand side into like a atrium area, we've now got swans, and swans are a really important part of Burton. So it was lovely to bring those, and we had a company who sponsored and paid for those swans. So if you do head over there, take a look. And just a final thing really about Christmas. So, you know, Christmas is a time of giving. We're very lucky in the hospital in the fact that lots of people like to give at Christmas. So we have lots of people that contact us who want to bring in gifts for the children and others on the ward. But as I mentioned, as a charity, we do provide a gift to every patient in hospital. So on the top left, you can see we've got some blankets and some little wash kits. So they're the gifts this year. And the other thing we're doing this Christmas is fundraising to purchase a mobile sensory unit for children's outpatients, so that if children are anxious when they come into hospital, they can kind of interact with the bubble machine, and that to really sort of help them relax. So we're doing an appeal around that. So that's it for me. Thank you for the opportunity to speak to you all, just to let you know what's going on, and have a lovely Christmas, everyone.
Thank you, Ali. You've shared a lot of information in a short time, so thank you very much. So I'd now like to introduce Suzanne Phelan, who's the Parkinson's disease nurse specialist, and Fiona Lindop, our specialist physiotherapist. They're from the Centre of Excellence Parkinson's Care that we have. There will be time at the end of the talk for questions and answers. Thank you.
Thank you very much. Been told we have to hold the microphone, so can you hear all right with that? Okay, thank you. Probably just best to explain at the beginning that, let me just check that works, is although I'm a specialist physiotherapist, I have just retired from clinical practice. I have an honorary contract with the Trust, which means I'm still kind of teaching and doing some supporting research, but I'm no longer seeing patients. So I'm kind of here as a guest speaker tonight. But Suzanne is definitely still working for the Trust, and we're going to do a sort of ant and dec tonight. So what we're going to talk about is who gets Parkinson's, what Parkinson's is, and why people might get it. And then we're going to talk a bit about what can be done to help it and who might be able to help. And then we're going to tell you all about the Derby Parkinson's service here, because it's a very special place. So people often say, why is it called Parkinson's? And sometimes they say, I don't like Mr. Parkinson, whoever he was, because nobody wants a diagnosis of Parkinson. But Mr. Parkinson was actually Dr. Parkinson. He was a GP and an apothecary in London. And he wrote the Shaking Palsy in 1817. And in that essay, he described what Parkinson's is. He did it on 3 patients of his own and 3 people that walked past his house every day. But he was very accurate. It was about 60 years later before it was actually then named after him. People with Parkinson's are in good company. You might recognize some of the famous faces on here. We've got Ozzy Osbourne. It depends on what you think about whether that's good company or not. Billy Connolly, Neil Diamond, Michael J. Fox, Muhammad Ali and Paul Sinner, and I could have put hundreds more on there because there are lots of famous people with Parkinson's. But when I first started out as a physiotherapist, even as a student, hardly anybody famous had Parkinson's. And the message out there wasn't very encouraging. And the world has really changed in the last few decades. It is the fastest growing neurological condition in the world. And it is a progressive neurological condition, which what actually happens is that you start to lose some of the nerve cells in your brain, and you particularly lose a chemical in your brain called dopamine. But you don't get the first physical symptoms of Parkinson's until you've lost more than 50% of that chemical, probably more like 70%. So a lot is happening in somebody's body before they get a diagnosis. And it's only once they've got the diagnosis that actually the treatment can begin. When all of those things are happening pathologically, you get some physical symptoms, and you also get what we call non-motor symptoms. And we'll talk about them in a few minutes. But first, we'll just talk about how many people get Parkinson's. And at the moment, there are 166,000-ish people in the UK with it. They are distributed mostly like this. Most of them are in England. But there are 20,000 people, they reckon, who still haven't got a diagnosis, but who have Parkinson's. And they haven't got a diagnosis because they're still waiting to see a neurologist or somebody else who can diagnose it. And if you live in Northern Ireland, you could be waiting 5 years to see a neurologist. So the situation in Northern Ireland is not good. Average age of people being diagnosed is 69, so it does still tend to be talked about as an older person's condition, but actually quite a lot of people are younger, and 1 in 16 are under 50. If you're under 50, there's a suggestion that it could be a genetic form of Parkinson's, but most people have what we call idiopathic Parkinson's, which means we don't know why you've got it. There's no apparent reason. And 1 in 3 people are of working age, which means they're under 67. So it does affect how people are living out their lives and also carrying on in their jobs. So this year, about 28,000 people will be diagnosed in the UK. And as I said before, 20,000 are waiting for a diagnosis. So park that bit at the side. But for those 28,000 people, that's 1 person being diagnosed every 20 minutes. And that's a really fast progression for a condition. It affects more men than women. We're not absolutely sure why, but there's a few potential reasons why it could be. It's 59% of men to 41% of women. Some of these figures are from this latest paper that was out earlier this year. So these are quite recent figures. But in this next slide, you can just see how much it's grown since 2018. And when I was doing these talks, probably I did a health information talk in 2017 with Suzanne. And when we did that in 2017, the figure was more like 120,000. So you can see how much it's growing, but we still don't know why. We don't know what causes it for sure. We've got ideas, but nobody knows for sure. And a lot of the research being done is about trying to find out what causes it. Because if we could find out what causes it, then we could treat it to slow it down or perhaps prevent it. There are lots of things we can do that are very positive that can help people live well and possibly slow down the condition. But until we know what causes it, we can't prevent it. So there are some things that could increase your risk of getting Parkinson's. One is being a man, and it's also being older. Another is for about 10 to 15% of people, there could be a genetic link in their family. But for most people, there's no genetic link. But there are those few where there is. So if somebody has a first relative, like a brother or a sister or a mother or a father, and they have this genetic link, they're more likely to get Parkinson's. Having a head injury and also exposure to metal can increase your risk. So sometimes people work in industries where they work with heavy metals. Paraquat, I bet you can remember paraquat from the days when we all had it in the garden shed. Paraquat is one of the probably the biggest things that we think is linked to Parkinson's, and along with other weed killers. So if you do use weed killer, be very careful. You can't really buy paraquat these days, but it is still used, I think, in farming industry, and it's still used in America and other countries. Rural living, possibly because the pesticides are put on the ground, means that you have an increased risk, as do you if you drink well water. And there's also a link with possibly flu, which isn't great at the moment. While there's a big incidence of flu at the moment, but they think that inflammation in the brain and in the body could perhaps trigger Parkinson's. And there are some links with particularly the flu virus, even though that looks like a COVID virus, it's actually a flu one. The good news is that there are things that you can do that can reduce your risk. And one is drinking coffee. It does have to have the caffeine in it, so it's no good if it's decaf, although decaf's sometimes better for you. I think you'd have to drink a lot of coffee for it to make enough difference. And some people would get side effects from the caffeine anyway. Another one not to be recommended is smoking. People who smoke are less likely to get Parkinson's, probably because the nicotine attaches to the receptors in the brain and prevents the dopamine being released or escaping and being destroyed. But the other really good one is exercise. And exercise can make the biggest difference to people with Parkinson's, a massive difference. We now think it's just as important as medication. So if somebody has got Parkinson's, the way that they will get a diagnosis is they turn up in a clinic and they have something called bradykinesia, which means they've got slow movement. And they're often asked to do finger taps to see if one side will go smaller and slower. They'll also possibly, you must have bradykinesia to get a diagnosis, but then you could have any of the next few. So you could be stiff, so it's a cogwheel rigidity. So it's like a ratchety stiffness that they will take your arm and do a passive movement on it and get this ratchety movement. And you may or may not have a tremor, but only 2/3 of people with Parkinson's have a tremor, a third don't. And there's tremor-dominant Parkinson's type, and then there's one called postural gait instability, which kind of means your balance isn't great, which I put on there. And then there are a whole load of non-motor symptoms that you can get as well that are not so easy to define, but the person with Parkinson's feels them. And this cartoon was drawn by somebody who was 45 when he was diagnosed. He's an A&E consultant in Leicester. And since his diagnosis, he's still working, but he's also doing a lot of artwork. And he drew this figure who has all the symptoms of Parkinson's, motor symptoms and non-motor symptoms in his body. The non-motor symptoms, there are a whole range of them. There's a form that you can fill in to see which ones you've got, and it has 30 questions in it. And people often have more than one of these symptoms as well. They can have sleep problems where they can't stay asleep or they can't get to sleep, or they have dreams where they act out the dream and hit the person in bed with them. They could have mood changes. Often depression can be present before a diagnosis of Parkinson's. Might find themselves very anxious. If they had anxiety before, it could be worse. Maybe they weren't anxious before, but now they have it. They might have apathy. They just can't be bothered. But they might also have fatigue, and that is fatigue that you can't really explain. You wake up in the morning and you just feel exhausted, even though you slept well. So this is another non-motor symptom that's quite difficult for people to explain. And they might have hallucinations, which are usually a side effect of medication. They might have sensory disturbance where they're more sensitive to pain. They might feel a light touch is uncomfortable. And they could have problems with constipation. Their blood pressure might drop. They might need to go to the loo more often because their bladder's a bit more irritated. And they can experience sexual dysfunction as well. So there's a lot of things going on in the body. And there's talk about calling it a syndrome rather than a disease. It isn't a disease as such. It's a combination of lots of symptoms. And because of that, you need lots of people to help with it. But getting a diagnosis of Parkinson's is quite difficult to come to terms with for a lot of people. It's a shock. It's not what they were expecting to do with what's often their retirement. It changes the relationship sometimes within the family, because you suddenly you're dealing with a condition between the couple or the family. So a lot of the people working in the Parkinson's world are helping people come to terms with the diagnosis. And because of that, you need a lot of people in the team. Medication alone can't reach it. You need an MDT to do the things that the drugs can't do on their own. So the interventions that can be done are medication is very often started as soon as you get the diagnosis. Surgery is offered, but it's usually offered to people who've had Parkinson's for quite a long time and where the medication's not so easy to get balanced. And then you need a multidisciplinary team, which is what we have here in Derby. And that team will look very different depending on where somebody is in the country. But they reckon that the basis of an MDT for Parkinson's should be a doctor, a Parkinson's nurse, physiotherapist, occupational therapist, speech and language therapist. Those are the core, but then you might well have other ones. And I think Suzanne's going to touch on that a bit later on. There are some principles that the whole team need to understand in order for everybody to be working to help the person with Parkinson's live their best life despite the diagnosis. And that the team need to understand, and then they need to help the person with Parkinson's and their family understand what it is that goes wrong when you haven't got that chemical in your brain. And it's things that you learned to do well that you didn't probably even notice you were learning when you were little, or sometimes later on. It's well-learned complex movements that used to happen automatically that don't anymore, like getting out of a chair or getting out of bed. Probably, if you haven't got Parkinson's, you probably didn't think about how to do that this morning, unless you got a bad back or a bad leg. But if you have got Parkinson's, it's that complex, well-learned movement that you can still do it, but the process of how to do it isn't automatic anymore, and it can make it difficult. You can also have trouble doing lots of things all at once. It means that you don't have that automatic ability to store lots of things in your head and to make switches where you might be, there can be a physical thing that you're doing, like walking in a straight line. You suddenly need to run across the road because a lorry's coming, and you can do that easily if you haven't got Parkinson's. But with Parkinson's, that switch of speed or turning around to run the other way, or just doing different things very slickly can be a little bit more difficult, as can thinking about lots of different things. If you're somebody who likes lots of random thoughts about things and you're having a conversation with them and you're struggling to keep up, somebody with Parkinson's might struggle to keep up a little bit more if they're not on their medication. And they need a little bit longer to just process questions and ideas before they respond, because they're processing it, not automatically, but they have to do it consciously. So the team needs to understand that and give people just a few seconds longer to answer questions. And our principles of intervention are to get somebody to pay attention to what they're doing and to either help them to do two things at once. So sometimes walking and carrying something means that the walking isn't so good, but we can train that. Or if it's dangerous, we can actually say, don't walk and talk because you might fall. And then we use something called cues and strategies. And the cues could be from within the person or outside the person. If they're inside the person, the list we have here is them paying attention. The emotional set means that they need to think positively about what it is that they're going to do, because that actually has a link to another area of the brain. They can mentally rehearse what it is they're going to do. So if they imagine walking with big steps across the road, and then do it without interruption, it can be a much better quality walk. They can visualize something that isn't there, like a person to walk around, or a line that isn't there on the floor, but they could use the imagination of that line to walk over. They can talk to themselves about giving themselves a song or a rhythm. If maybe they get freezing where their feet feel like they stick to the floor, and giving yourself a rhythm or a song can help with that here in your head. And the proprioception is something that they produce from their own body. It's just if you can't take a step forward because you have this thing called freezing, you can rock from side to side or take a small step back and then step forward. So we can teach all of that as these sort of cues for people to manage their own Parkinson's. External ones are making sure that the area that somebody is trying to do something in isn't too busy. We can use visual cues like laser beams on the floor. We use laser pens that point a little dot on the floor and somebody can step onto that. Or we use post-it notes to get somebody through a doorway without sticking. They often freeze in the doorway because their eye has seen the door frame subconsciously. But if they focus on a post-it note on the wall beyond it, they can go straight through without stopping. We use auditory cues. Physios are very good at saying big steps in bossy voices. We're very good at being bossy. But we could use music or a metronome as well. And music has all sorts of other qualities to it. It can actually improve somebody's walking and turning and everything just by them playing a song that they really like that's got the right rhythm. And sensory cues are also available that buzz on your wrist to remind you to do something or to remind you to swallow. So we've got lots of things that we can teach and use. An example is when people are trying to get out of a chair, that automatic movement that isn't happening properly anymore is because they're trying to come up like a helicopter taking off. So without realizing it, to get out of your chair, if you haven't got Parkinson's, you will all move forward. You'll bring your bottom forward, or else the top part of your body forward. But somebody with Parkinson's might miss that bit and try to come out from the back of the chair, which is almost impossible. So, no helicopters. You need to come up like a plane taking off. And just giving that idea to somebody can actually help them get out of low sofas when they've gone to visit a friend, chair, anywhere else. The ability to do it is often still there. It's just that processing. So a quick sort of rundown of what the different members of the team can do. I'll talk about the therapists and Suzanne's going to talk about the others. The physios do the kind of things that you would expect physios to do. So we're always talking about exercise and physical activity because it makes a huge difference in Parkinson's. We do a lot of work on walking to help people avoid falls and to make their walking a bit better and to help them to avoid this freezing. We do a lot of balance work. People with Parkinson's are more likely to fall. They're also more likely to fracture because they're more likely to get osteoporosis. So we need to make sure they're as safe as possible. We can help them with those transfers, getting out of chairs, off the bed and off the floor. Posture becomes a bit flexed. We don't want that. So we need to get in there at the beginning with some pictures, either of what their posture is like, but we also measure it against the wall. And education and support. All the therapists, all the nurses, all the doctors talking education and support the whole time to enable the person with Parkinson's to manage their own condition, because they're the ones managing it most of the time. They're not seeing the health professional very often across a year. Some of these pictures are quite old, and some of the people in these pictures are sitting at the back, and these are about. Which is why one of the people in the back, this is when I was still working, but Liv is on the back row, who is now the lead physiotherapist in the team. And Rachel is the one here that you can see on the left, and it is from about 15 years ago. But occupational therapists, most people think occupational therapists provide equipment mostly. And although they do that, in Parkinson's, their role is so much more. They can help people with their sleep. They do lots of things called sleep hygiene, and they can help people pace their day to manage fatigue. They can help with low mood. They can help with when you get mild cognitive impairment, where your thought processes aren't so clear. They can actually give tips and help for managing that. They can help with apathy, which you would think that's kind of hard. And actually, exercise can help a bit with apathy. But the OTs are doing a huge amount of work on these non-motor symptoms. And they give advice and education and signposting to other things and other support. And they do give out aids and equipment as well. Speech therapists are people with Parkinson's. Their voice is usually a little bit quieter without them realizing. So they do a lot of work on volume and how fast they speak or how slow they speak, and whether it's monotonous or needs a bit more tone. They work on all of that. People with Parkinson's often have a bit of a problem with drooling, so they can help with that. And also, we need to warn people that they may have a problem swallowing in the future. And sometimes just because you don't, if you're talking and trying to eat your dinner at the same time, you might be a bit more at risk of something going down the wrong way. So they do a lot of work on swallowing as well. And in a moment, I'm going to hand over to Suzanne. But if you have got Parkinson's and you're in the room or you're online, the good thing is that Derby is a centre of excellence for Parkinson's. It's been awarded this from an American charity called Parkinson's Foundation, and we've been a centre of excellence since 2008, and there's only 2 in the UK, King's College London and Derby. So, and we've been given ours because of the multidisciplinary team work that we do and the research that we're involved in, but mainly the MDT. And that was our revalidation visit this year, which was done in June, which means that for another 5 years, we are still a centre of excellence. And at this point, I'm going to hand over to Suzanne with both bits. That there, the side one. This one, yeah. This one. Okay.
Good evening. Can you hear me? So I'll carry on. So as Fiona pointed out, we are a national centre of excellence. And so what does our Derby Parkinson service look like? So it's split into a older adults pathway and also a neurology pathway. The neurology pathway is mostly based at the Royal Derby. We have 5 consultant neurologists. One of those is a consultant in movement disorder and Parkinson's. And we mostly see all age ranges at the Royal Derby. But predominantly, we do see the young onset Parkinson's patients and patients with an atypical condition such as MSA, PSP, or CBD. We do find that the clinic over at London Road tends to see our older patients over 60. However, we have got some younger patients that we've allowed in. This is a clinic that's run every Friday within the multidisciplinary team. Occasionally, the consultants are able to do ad hoc clinics due to annual leave or long waiting lists. And we've recently been able to set a Parkinson's clinic up over in Burton, because many of our patients live in Burton, and it's a little bit more local for them, and they don't want to travel to Derby. Sorry. Okay, and I'm very loud. Can you hear me okay now? Okay, apologies if I've deafened everybody. The only thing that we haven't got over in Burton is a full multidisciplinary team. It's more consultant-led. But hopefully, in the near future, we're hoping to partially mirror what we've got in Derby over in Burton. We've got 2 Parkinson's disease nurses, myself and Lisa Brown, and we've both been in post a long time. We are also responsible for clinics run at both sites. So on a Friday at London Road, and also at the Royal Derby, between us we run 5 clinics over a weekly basis. Lisa also does botulinum toxin clinics twice monthly. And I'm also involved in our Parkinson's outreach service, supported by our Parkinson's clinical fellow who has a year's post with us. And we're able to go out and see the patients that are not able to access our clinic due to advanced condition, frailty, or maybe they may be nearing their end of life, and we can support them in their environment. Again, as Fiona said, we can refer to individual therapists as required. We don't necessarily have to do that at the start of somebody's Parkinson's journey. We can do that if symptoms arise. For example, if somebody's experiencing poor sleep, and that's something that's not a new onset, we can refer to the OTs for sleep hygiene. Again, we know bladder and bowel instability is a main non-motor symptom in Parkinson's disease. So we're really lucky to have one of our staff nurses has been able to set up a continence clinic based at the Florence Nightingale. So we can advise and refer patients to Amanda, who ultimately can also refer further on to urology. We're very lucky to have a clinical psychologist involved, Dr. Cobley, who can support patients that maybe are coming to having difficulty coming to terms with their diagnosis, or having increased anxiety and stress levels, which she may be able to help with. We're also extremely lucky to have a consultant psychiatrist with a special interest in Parkinson's, who is part of our clinic on a Friday. And again, he can see patients that are really struggling with their cognition or their anxiety and mental health. And we also have a monthly palliative care consultant at the moment. That's Dr. Sarah Awan, who is based in the Macmillan unit, but she is able to come over and see our patients in a clinic on a Friday. So who's in the team? Again, we can go through it. I will just point out that when we initially first started our Parkinson's clinic, it was normally a consultant, a Parkinson's nurse, and a registrar. So now, we have got a full team involved, which enables us to see more patients. It increases patient capacity. But what it has done, it's given the existing team, knowledge and skills to move forward in helping our patients live with Parkinson's disease. And one thing I want to highlight is the palliative care consultant. So she may see people that are more of an advanced stage of their condition, or they've got an atypical, more progressive condition, and she's been benefiting patients in starting that conversation and looking at advanced care planning when patients come to the end of their life. But again, she's been fundamental in allowing us to start that conversation, which is never easy, and giving us the knowledge and skills to move forward in looking after our patients. So I quite like this slide. It's an ideal MDT, and again, it shows you the core people, the neurologist or geriatrician, the speech therapist, the person with Parkinson's and their carer is at the heart of that, and all the peripheral specialists are, so important in managing both a patient's non-motor and motor symptoms, as Fiona said, which are, prolific and affect somebody throughout their journey of Parkinson's disease. And again, we can tap into these other allied health professionals as a person with Parkinson's journey progresses. So the MDT, what can they offer the patient? I'm going to just concentrate on three. So education and information sharing. We are really lucky to be able to offer patients groups within the setting at Florence Nightingale. We do a Parkinson's education group for patients who are newly diagnosed or reasonably newly diagnosed, and they can come along with their carer or a member of their family. And we talk about many stages of Parkinson's, which may not be affecting them at the time, but they can relate back to that. But what that helps to do is form bonds and share experiences with other people experiencing that lived experience. Those little things make such a difference. So people's tips and ideas allow patients with Parkinson's and their families to become empowered. They can manage their disease throughout its duration. And as Fiona said, we always encourage our patients to be self-management. We don't leave them unattended. They know they can always contact the Parkinson's nurses, the consultant secretaries, or a member of the MDT at any time if they're having an increase in symptoms or experiencing problems. So as Fiona said, we have a weekly Parkinson's nurse. And within that clinic, we've always got a physiotherapist and an occupational therapist available. And that's in case somebody's been experiencing poor cognition and it's only been highlighted at that clinic appointment. We can then carry out a possible cognitive assessment, which we can then discuss at our MDT. If somebody attends clinic and they've been falling, they're experiencing episodes of freezing, or the equipment that they might be using is not appropriate for them, they can have a physio assessment within that clinic appointment, and then we can discuss that person afterwards. So it really is, as at the end of as they say at the end of the slide, a one-stop shop. Even if they don't see everybody on that same day, we can access them at some point. We also have our meeting, which seems to get longer and longer. So within a normal clinic, because of the increased members of the clinic staff, we tend to see between 20 and 30 patients in each clinic. So we discuss all of those, but we also have a virtual clinic. So if anybody rings up during the week and they're having a problem, or we've got a new referral, we're not sure what to do, we can discuss that with the team and then inform the patients if there's going to be any changes moving forward. Or if somebody's experiencing an exacerbation in their symptoms, we can arrange and expedite a sooner appointment for them. So I'm just going to talk a little bit about the Parkinson's role. So there's myself and Lisa, and we cover both sites here and the Florence Nightingale. We are specialist practitioners in Parkinson's disease. I've worked for the service for 18 years, but I've been a Parkinson's nurse for 9 years. Lisa's been a Parkinson's nurse for 20 years. So, you know, you're not going to get rid of us any day soon. We can coordinate comprehensive care with people, and we've got about 1,500 patients between us. We provide regular reviews over the phone or in clinics. As I said before, Lisa and I, over the course of a week, do 5 clinics between us. We can see patients in clinic, and if they need to be starting medication, we can prescribe medication for them to start immediately, so they're not having to wait for the letter or the GP to negotiate the prescription for them. If we need to discuss patients that are tricky or we're unsure, then we can go to our senior consultants or neurologists. So we always ensure that we work within our boundaries of knowledge. We can commence and adjust medication, and we can provide information and education about all aspects of Parkinson's disease. And we are a lead on advanced therapies, so we can refer to Nottingham, to Queen's Medical for non-oral Parkinson's treatment. And we've been able to roll out this year a new treatment called Produodopa, which is specifically for people with fluctuating motor fluctuations. And we are aiming to initiate this on 1 person per month, because we have quite a lot of follow-up in those days. We've just initiated a lady this week, and she's doing amazingly well. So when a person is diagnosed with Parkinson's, they are referred to me by letter or verbally by email. So I'm probably their first point of contact. They are also given information at their diagnosis with the Parkinson's nurse's contact details in. So we aim to make contact within 4 to 6 weeks. However, I have been known to call patients to call me 2 or 3 days after they've been diagnosed. So how are they? You know, have they been able to process any of the information, if any, when they were given that diagnosis? How are they feeling? If they've got the letter in front of them and they've got the medication, great. Do they understand what's happening, what their diagnosis is, and what the plan is going to be? We can go through medication with them. A lot of the time, patients, there's differentials between what's actually in the letter and what's actually on the medication box. So that can cause confusion with patients. So we go through step by step, especially if they're starting on a low dose and up titrating of their medication. Usually it's quite early days to see if they've actually started medication, but have they noticed any benefit from it? Has it made a difference? Have any of their members of family said, you look a bit brighter, or you're walking a little bit better? Has it caused any side effects? Has it caused nausea? So that's one of the main initial side effects. So we always counteract any new medication with asking the GP to prescribe some anti-sickness tablets. Have they needed to use that, or would a ginger biscuit suffice? Has it been identified that they're driving? Have they been advised that they can continue to drive, but on the premise that they inform the DVLA? Is that something that they've already done, or are they in the process of doing that? And then we normally, both at Florence Nightingale and here, we do a follow-up appointment within 3 to 4 months of that diagnosis, ensure they've got our number and safety net if they have any problems with their medication. And it also gives us an opportunity to start an electronic patient contact record, which we document that we've spoken to that patient and their follow-up is as planned. And Lisa and I can add into that document at any time through that person's journey with Parkinson's, whether it's a query, a bit of reassurance, or a GP letter that's been identified. So when we actually see the patient within 3 months, hopefully they've been established on their medication and they can actually highlight if they've had any benefits. So we can look at medication response, if it's caused any problems. We can actually examine them, or actually they're the experts. I'm walking a bit better. My tremor's not so good, but I'm feeling a lot better in my mood. So the dopamine can affect patients in lots and lots of different ways. Are they actually taking the medication the correct way? Because believe me, I've had some horror stories. And is it proving beneficial? Are they having any side effects? Once they've been on the medication a little while, we can establish if they're experiencing any excessive drowsiness, any dizziness, any non-motor symptoms such as hallucinations, dreams, REM sleep disturbance. Have they been able to inform the DVLA? How's driving going? Are they experiencing any problems? What are their plans to continue driving? Normally, at their initial diagnosis, they are referred over to the team at Florence Nightingale. If that's not happened, then we talk about if they're interested in being referred over. If it has happened, have they actually had contact with the team? And another really good device that we've got now is if they have had therapy follow-up, we have electronic MDT notes, so we can quickly just look on Lorenzo on our electronic system and see if they've had a cognitive assessment, what have they got, if they've had a physio assessment. So it's really been beneficial and it's really streamlined our consultations. Again, we ensure that we signpost if we're starting any new treatment. We ensure that the patients are aware of any potential side effects and it's clearly documented in the notes. And we ask patients if they're interested in any research programs. We signpost them to Parkinson's UK, and if they are, we can put them on a database and then they can be contacted when any research projects are initiated. So as Fiona said, the Parkinson's MDT service can differ across the region. Some MDTs have got very small groups. Some people have got an extensive MDT like we've got in Derby. Roles can be different, but we can, our main aim is the person, it's patient-centred care, and we want to provide a holistic approach. Frequency of meetings, even though we have them on a Friday, if myself or one of the OTs or the physios is concerned about a patient, we can do a Teams meeting, we can do it over email, we can do it over a coffee. So there's flexibility on frequency of meetings, and again, settings. We can do that within a nursing home or in a patient's environment if we want to involve the MDT, and we can do it in our clinic settings. So basically, to summarise, our role is to act as an overall coordinator and our main point of contact with person with Parkinson's disease within all settings. Early intervention, so making that first initial contact with patients is key really to following that patient with every stage of the journey. And involvement of the wider well-informed MDT is key to the complexity of the condition. I'm going to hand over to Fiona now.
Thank you. I'm just going to tell you in the last few slides a few of the things that have put Derby on the map really in Parkinson's. And one of the first things we did was we had the first Parkinson's fellow in the UK. This is a doctor who's in training, already qualified, but doing postgraduate training, and they take a year out to specialize in Parkinson's. And we did it 4 years ago, and the latest fellow is sitting in the room. So there are now some that are funded by Parkinson's UK charity, and 1 or 2 other places in the country have done them, but Derby was the first. And the fellow that we had at the beginning, the very first one, started a community outreach program so that for patients who were maybe living in care homes or who were housebound, couldn't come to a clinic anymore, they would go and see them at home and actually make sure they were doing a community service to make sure that that person was getting the best care. We don't want people forgotten just because they can't get to an outpatient department. Another thing that the team did was we put a bid into Parkinson's UK for some funding, and we got 2 years of funding for a physio and an OT to go onto the wards to get people with Parkinson's out quicker, basically, because people with Parkinson's tend to stay in hospital longer than people who don't have Parkinson's, and they often don't get medication on time, and various things can delay that discharge. So 2 years ago, 2 and a bit years ago, we had the physio and the OT were set up. They had to set the whole thing up. It was a brand new thing. We'd never done it before. And again, we were the first in the country to do this. We weren't the first to get an allied health professional bid from Parkinson's UK. There were a few others at the same time, but we were the first to do this rapid service. They also do community visits. If somebody's in crisis, they'll go and see them at home to try and prevent a hospital admission. And for patients who have been in, they will do a phone call to check that they're managing at home okay, again, to try and avoid them being re-referred back in because they're not coping or something that was supposed to be delivered at home hasn't been delivered. We're also involved in a lot of different research projects, and there wasn't going to be enough space to put all the ones that we'd been part of on here. But the team is involved in various multi-center studies and pointing patients to research. We did a study over 10 years ago now where we trained one of the wards in the DRI. Everybody, including the receptionists on the ward, were trained in Parkinson's, and we showed that we could reduce the number of days that patient stayed in, and they had all sorts of other better experiences as well. So if everybody is trained in how to look after people with Parkinson's, it's far better. Trouble is that ward staff tend to change quite a lot, and it's quite difficult keeping up with everybody doing the training to keep up to date. We've had something called PEEP, which was online physiotherapy during the pandemic. That is finished, but the paper is it's been submitted to some journals ready for publication. Stroll is one to do with augmented reality, which is about to take off, and the team are going to be involved in that. It's happening in 1 or 2 other centres in the country, but Derby is going to be one of them. Various other things are going on as well, but we're also part of the Parkinson's National Audit, which happens every 3 years, again, to make sure that people with Parkinson's, wherever they are in the country, are getting the best care. And if they're not, highlighting what services are missing. And once a year, we run a patient symposium. So we run on a Saturday, various workshops, and some keynote speakers will come and give some education and fun workshop opportunities to people with Parkinson's. And it's happening in March next year at Florence Nightingale, and there will be more details about that in the new year, I think. Another thing that Liv, who is on the back row, the physio who's now the lead there, she was able to set up in a conjunction with Derby County Community Trust, a Derby walking football team. And once a month, Liv and several of the members of the team volunteer their time and go and support people with Parkinson's playing football. And apparently they love it. They throw themselves around in the goal, giving everybody a heart attack. But it's you're not allowed to run. If you want to know more about it, you have to ask Liv and Rachel. But it's a national thing. There's a national team that plays in Europe as well. So that's been a wonderful thing for people with Parkinson's. They're all loving it. There's a women's team now as well, which again they've set up. And one or two of the other things that we've flown the flag for the Trust is we run national courses in Parkinson's and atypical Parkinson's. We run 3 courses a year. And that's one of the reasons why I've got the honorary contract, 'cause I'm carrying on teaching on those. The company is called Training Made Easy that runs those for us. Parkinson's UK is the big national charity for Parkinson's. And Claire Johnson, who is a specialist occupational therapist in Derby, has set up an occupational therapists hub for the whole country, so that occupational therapists, wherever they are, can get access to information and support and training. Caroline Bartliff, our speech and language therapist, has set up the Speech and Language Therapy National Hub, and the speech therapy one does the same. That's quite new. There's an exercise hub. I supported them setting that up. Some other people in the country were doing all the work, but I had a role in Parkinson's UK until earlier this year as the National Clinical Therapy Lead. And as part of that, I was supporting them setting that up. And that's still running, now has over 900 members, I think. And Claire, the occupational therapist, also helps set up a younger onset Parkinson's group that meets in Derby, and also one meeting in Uttoxeter. And she goes along and supports those working age people who are meeting together. Lisa Brown, the other Parkinson's nurse, is the chair of the Parkinson's Disease Nurse Association for a little bit longer. Is that right? Yep. We wrote a book, a handbook for people who might come across a patient with Parkinson's but don't know what to do. So we wrote a handbook that should tell them whatever they should do with whatever the problem is. We got 33 authors to write altogether in the book, and nobody else has written a book like that. So that was published in the end of 2021, and it's still out there. And this is really a team thing. Somehow I ended up with an MBE last year for services to Parkinson's and physiotherapy, but it was a team thing because I couldn't have done what I've done over the decades without the team. And it's really a Derby thing. So that's for the team. And I think that's our last slide. Just to say, I've loved working in the team. I've done it. I've been working in Derby since 1992, and I was in the day hospital for the elderly from 1994, and we started seeing Parkinson's patients straight away, but only a few. And then it's just grown like Topsy until now it's a Parkinson's service that just is amazing to work in. If you have Parkinson's, you're in the right place. Thank you.
GPs and other people are recognising Parkinson's, and therefore it's not actually going up, it's just being diagnosed better.
Although I think there are some places where it's diagnosed better, I think there are also, it takes quite a long time to get an accurate diagnosis. So unfortunately, I think it's on the increase. It's not just that it's being diagnosed better. People obviously are living longer than maybe they did 50 years ago, but the way that they're expecting by 2065 that will have doubled from 2018. So that's not just people getting a better diagnosis, that's across the world as well. So is it the pesticides? Is it all the particles that are in the air? Is it a combination of that plus the environment plus your own genetics? Lots and lots of research going on to try and get to the bottom of it. And if you're interested, Parkinson's UK do a magazine every quarter, I think, called Progress, which shows all their research. And there's a lot of scientific ones going on, just trying to find out what's the link.
Are we sort of, are we any sort of worse or better than other countries? Or is it national, throughout the world, is it more or less the same? every country.
There are some differences across the world in how many people have got Parkinson's, I think, and certain populations are perhaps less likely. But I think we are sort of on a par with America and other sort of industrial nations. In the UK, we have medication to treat people with Parkinson's, which is a given. In Africa, they don't. In Africa, they actually have to grow. They're given some beans in some parts of Africa to grow a plant that produces a bit of dopamine. It's not enough, but it's better than nothing. So I think equality of care is not there. The World Health Organization's done a thing about what should be available for people with Parkinson's, whatever the economy of the country, but it's had to keep it really basic. There's another question on the front row.
People are referred to you. You obviously
The microphone's coming.
Microphone's coming.
Slowly but surely.
So when people have Parkinson, they're referred to you. You obviously assess them to whether you think they have Parkinson's or Parkinsonism. So you have to wait for a long time for a DAT scan to clinch the diagnosis. Is that correct?
Yes, so if the diagnosis is unsure, we know that the DAT scan is a you've got Parkinson's or you haven't.
Yeah.
Unfortunately, there's around a 6 to 9 month wait for that. So a lot we tend to the consultant neurologists here tend to refer for DAT scans if they need to. But however, if they feel that that person would benefit from levodopa treatment, they would start them on it rather than wait 9 months and then they've missed that 9 month window. So just to see if they've got a response to that, and then they'll get their DAT scan. But because they're very expensive, there's a long waiting list. They're quite invasive. Then we would only the consultants would only refer for a DAT scan if the patient had a poor response to the medication, or their symptoms changed, or they were a little bit unsure. There wasn't, they weren't quite, not quite sure. We'll start them on some treatment and arrange a DAT scan. So
anyone who doesn't respond to treatment very well, they are suspicious.
Well, we may try alternative treatment. So there's two types of levodopa, co-beneldopa and co-careldopa. They're very similar, but some people have a better reaction to one. So we wouldn't normally just go straight in and order a DAT scan. Sometimes it's best to watch and wait a little and to see if symptoms progress.
The other thing is, you talked about genetic testing. I mean, that's all in the fashion for genetic testing for everything now. Do you refer any of your patients for genetic testing?
Personally, I haven't, but I know some of the neurologists, I think they do it over in Nottingham at the City Hospital. So not very often we refer.
What would be the criteria that would... family history?
Family history, or... So if I can just think back, I think there was probably 2 or 3 members, not in immediate family, but within that family dynamics that have got potential Parkinson's, or they've had family members that have probably had a tremor, never been diagnosed, and are now no longer with us. So, but yeah, we don't tend to do that as much. I don't tend to do that. So that's the consultants that tend to do that.
The other thing, some of the dysfunctional.
I think the other thing to add there is that
with old age.
the genetics, because if somebody has got a gene that means that they might get Parkinson's, at the moment we can't do anything about that other than tell them to exercise, and so therefore, if somebody is referred, they might need to talk it through about what will you do if you're told you have got that gene. They need counselling as well.
So what is the possibility, say you had a positive gene, would 50% of your children have the uncertainty?
It's not quite as clear cut as that, because there's at least 13 different genes, and depending on which gene you've got determines how likely and how severe it might be as well. So, and even 25 years ago, they didn't know anything about any of the genes, so it's all quite recent.
Thank you very much.
Okay.
The medicines that are prescribed, do they merely arrest the symptoms or slow it down or remove them altogether? You know, what is the...
Again, it's very different. You know, that little bit of dopamine replacement might just suffice in making somebody's movement a bit more fluid, their gait a little bit better. As I said, sometimes it doesn't always enhance the movements. It can make them feel a little bit more engaged, a bit more alert. Their mood can lift, because dopamine is that lovely, you know, chemical that, you know, makes us feel good, but also is responsible for the gait. So it's very individual to each patient, really. You know, and if they're not having it's a desired effect. Sometimes patients can have a really good response to levodopa, and then things may plateau a little, but that doesn't always necessarily mean that they need to increase the medication, because we obviously in Derby take a two-pronged approach. We look at medication, but we look at therapy intervention, which is just as beneficial to somebody with Parkinson's. It's not a case of giving lots of medication, because potentially then you're causing potential side effects, really. So sometimes the best thing to do with medication is nothing, watch and wait, but obviously reassure patients that they do, if they are experiencing an increase in symptoms, to touch base with us, and we can address that even over the phone. We don't need to see you in person. Hope that answers your question.
So once you're on this funny name of the medicine,
Levodopa.
you're on it for life, are you?
Yeah. Unless you have an adverse reaction, and we may have to swap you to an alternative, and that can happen. You know, not everybody. You know, we normally start with levodopa because it's very well tolerated. It's the oldest Parkinson's treatment that we can have, and you know, we can dose it out over the course of the day. But not everybody is suitable for that. Not everybody responds well to that. But yeah, once you're on it, unless you are started on it, have a DAT scan, and that DAT scan is normal, then there would be no benefit from the levodopa, really. So in more often than not, we tend to wean the patient off the levodopa. But again, individual cases, you know, we take it on an individual need. Okay.
Thank you.
That's okay.
I've got two questions, if you don't mind. I'm just wondering what the evidence is around people's diets as to whether that predisposes to a diagnosis of Parkinson's. The reason I ask the question is I have a cousin whose husband had PSP, and he would never eat vegetables. You know, I'm listening to your talk today, I'm kind of trying to think of where is the evidence. I'm interested in the research, really. So does diet play a part in it, an individual's diet?
Well, PSP is slightly different because nobody knows why that one happens.
I understand that.
But in terms of the diet, we think that Parkinson's could start in your gut and work its way up over 20 years to make its way to your brain. There's a possibility that's what happens. And obviously, constipation is an early sign. Somebody might have constipation in midlife and might go on to develop Parkinson's. Not that if you have constipation, you will, but people with Parkinson's tend to have had constipation as a problem.
Yeah.
So again, but it's not so much diet, it's about their guts slowing down and not sort of moving the food through at quite the same pace. If you've got Parkinson's, there's a suggestion that a Mediterranean diet is the best.
Yeah.
But there isn't any evidence to say that if you eat this or don't eat that, you will or you won't get Parkinson's.
Okay. And the other question that I had was, what is the evidence about the breakdown of ethnicity in terms of the occurrence of Parkinson's?
That's quite difficult to determine because quite a lot of people from smaller ethnic groups culturally won't seek help for Parkinson's. So we do have quite a few Asian patients, but it will be just on a national audit. The results haven't come out yet. They'll be out in March. But every time the national audit's been done, it shows that something like 79% or 85% of patients across the whole country are white British. and not Asian, and you get like 1% of black and 2% of Asian, but I think some of it's cultural, and it's what we call an unserved community, because we know that the Parkinson's is out there amongst them, and nobody can actually determine how many have got it, because they're often not coming to the GP or not getting to the neurologist to get a diagnosis.
Thank you. Thank you.
Finish them off. I think the message, if you want to take one message away tonight, is exercise makes the biggest difference. The medication can't slow it down yet, but they think the exercise can. But you have to do quite a lot of exercise. You have to push yourself outside a comfort zone. And you're being waved at, Val. Or some questions on Teams. So you definitely want to be aerobic exercise if you can actually, we think it could slow down the Parkinson's. That's the way the evidence is looking. So that's your message to take home tonight, is take the stairs if you can, park further away from the door of the supermarket. What's the question?
We have a question online. Is there a common link between Parkinson's and dementia? And if so, how are the two illnesses treated?
So people with Parkinson's, they can often get mild cognitive impairment at the beginning because it slows down the thought processes. Over many, many years, more people are likely to develop a level of further cognitive impairment. And that's why we have a psychiatrist on the team, because we treat it with medication and with therapy. So the occupational therapists do a lot of cognition groups and things like that, and support for family members who are looking after somebody who has developed a dementia. So it can be linked with Parkinson's. Otherwise, the treatment's the same. It's exercise, it's support for whatever symptoms you're having, and particularly occupational therapy and psychology if needed, and psychiatry. Want to add anything?
No, I think you've gone.
And Fiona, for a really interesting talk. It was really good, a really good question and answer session as well. Thank you for giving us your time. It's really appreciated.
Thank you for having us.
Thank you for having us. As I said before, it will be on the UHDB website in about a week's time on the Governor's page. I'd like to thank all the staff who've helped tonight, Ross and Phil, the AV team, and Alex with our teams. We've got quite a lot of people on Teams tonight. Our wonderful BSL interpreter who's worked very hard tonight, so thank you very much. And at least Fiona, our wonderful secretary, who's helped set all of this up, and she's wonderful. And we couldn't do it without her. If you've got a feedback form on your seat, please fill it out. We'd like to know what you'd like to do next with the next talk. So that'd be really good. Have a safe journey home, and we'll see you again, hopefully, about March time. Thank you.